Welcome to the For Health's Sake podcast, brought to you by Edito Health, elevating digital transformation with a human touch. This episode is sponsored by Radical Health Festival. It's critical to be radical.
Welcome. My name is Charles Alessi. I'm Chief Clinical Officer for Edito Health. And for this episode of the In Conversation series, I am joined by Professor Anja Tuulonen, who is the professor in ophthalmology at the Eye Center at Tampere University Hospital in Finland. And welcome, Anja. It's a delight to have an opportunity to have a conversation with you.
Thank you very much, Charles.
So really, because what you're doing is quite interesting, and I think people who are listening to this will be interested. You have been very active in trying to actually manage as precise a care as possible for individual and as evidence-based and as efficient care as possible in the field of ophthalmology. Particular in this new project which you're involved in called Asis. Could you talk to us about Asis? What is it and what are you trying to do?
Well, we founded the Asis ecosystem because, to put it simply, we wanted to know how our patients are seeing and doing under our everyday care. And as you mentioned, related to evidence, we have created guidelines and national access to care criteria. And we have had them for more than 20 years. But we know that we are implementing the guidelines in very different ways. And we did some benchmarking, productivity benchmarking, and we noticed that. And also there are huge differences in costs. And we ended up in agreeing that not all of us can be right. So we want to know whom of us would need to do something differently, do some things more that we are currently doing, some things less, or do things differently. And the only way to know that is that we need to collect structured data and then evaluate our real-world outcomes between different university clinics in Finland and also internationally.
I mean, this is, of course, one of the things we should have been doing for years, but we somehow never managed to do. We see this in places like cancer care as well, where even though there are guidelines, one, there is uncertainty whether we're actually following them, but it's more than that. Also, the costs are very significantly different in different places. And the outcomes may well be significantly different. So this is the sort of approach which you're adopting to try to get a feeling of the unwarranted variation which exists between different places. Am I correct?
Yeah, exactly. And so, for that, we have developed single entry tools, which means that everything that we put in the patient record will come out as a data which we then can evaluate in aggregated level. And we also develop a model how do we plan to do the benchmarking. And one special thing in ophthalmology is that in randomized control trials, patients have only one eye. But in real life, luckily, most patients have two eyes. And that's, we need to compare, are we comparing the better eyes, the worse eyes, and so on. So yes, there are very different things happening in real life compared to randomized control trials.
And I think that's absolutely correct. I mean, it's fascinating. I mean, what you're trying to do in essence is to ensure there is a single, a common data model, because that's the reality. So you can actually compare like with like. You can deploy everything from artificial intelligence to all sorts of different tools to be able to measure them. You may find this interesting, but I worked in England, and over the years we started to develop a liking for some work which a friend of mine was involved with, a chap called Muir Gray, who you know,
Yes.
around unwarranted variation, particularly in hip surgery. And we found that the area closest to where I practiced had a rate which was 3 times as high as the rate of the area I practiced of hip replacements. And the question I was asking, and this was many years ago when we're rationing care, I use that word because it was rationing.
Yeah, sure.
The question I asked was, do people who live next door to us have 3 legs rather than 2? Because somehow they're doing an awful lot more of hip replacements. But seriously, what you're doing is really important, because with a lot of these treatments now, especially things like the anti-VEGF treatments for macular degeneration, you know, the antivascular endothelial growth factor treatments, drugs like Avastin or bevacizumab, for example, these are A, they're expensive, and B, these treatments are for significant amounts of time in a significant number of people, and it's really important to get the best value out of them. What's your sense as to what you're going to find?
Well, to start with, when you mentioned age-related macular degeneration, we have had for years 6 or 7 times differences in drug prices. And for example, we are not spending a lot of money in Tampere, and there are other clinics which are spending much more money. So we would really want to know, should we do something differently, spend more money, or could the others actually save money and then allocate the saved money to something else? And when you mentioned about rationing or prioritization, this is something that we have been always doing, but it has not been very open. So
yes,
the decisions have been made by individual clinicians. And now we want to bring this up because I think that the resources are always limited. And for example, when I was leading Tampere University eye clinics, I thought that the budget was that at that time 15 million euros. Now it's 20 million euros. My job is to invest the money in such a way that it produces best possible well-being and the patients are seeing well. So if I put something, for example, more money to AMD and the total budget does not increase to the same extent, then we have to do something less for other eye diseases. So it's always trying to balance between different diseases, how much money we spend on them.
And this is always going to be a juggling, a line you have to walk across. But you're also doing something else which is very important, because I've seen some studies which were originally started in this space, and nobody was measuring outcomes. You're also measuring outcomes, and I find that very, very interesting, because it's all very well to say, yes, Tampere is spending far less than anywhere else, but without actually having a reference to what the outcomes are. You could be spending less than anybody else because you're under-treating all those people. You could be, you know, there's a various, I'm not saying you are, but there could be all sorts of reasons. And actually tying in outcomes is particularly important. How are you doing that tying in of outcomes?
Well, of course, we are measuring the clinical outcomes.
Yeah.
And as I mentioned, we are testing both better and worse eyes, because better eye always influences the quality of life. But the costs are, for example, incurred by the worst eye. So we need to figure out, well, what is the best way to measure the clinical outcomes? But in addition to that, we also want to know how our patients are feeling in general. And Tampere University Hospital and also Helsinki University Hospital have adopted using a general health-related quality of life instrument, 15D, which has a question for vision. And this is something that we have been using in Tampere since 2019. And the preliminary results show that this instrument reacts to eye diseases. And if and finally we want to do benchmarking, compare cost effectiveness, and we need the clinical outcome, we need the costs, and we need the general health-related quality of life outcome.
I think that last thing is ever so important, because you're not only measuring outcome in terms of the body part, not only the eye, in other words, you're
exactly.
also looking at the whole person using the 15D. We were using something called EQ50, which is a similar quality of life outcome, but more directed towards mental health. But this is not that dissimilar, and I think this is really quite important, because in essence, what you're doing is you're treating people like people rather than a set of eyes, whether 1, 2, or 3 eyes. And I think that is the fundamental issue. So that's great, and you're really going to get some very interesting data coming out of this. Now let's go a little bit further, because of course what's happening in Finland is happening all over the world. So what's happening in Finland is also happening in Spain, in Italy, in France, in Sweden, Norway. So are you doing any international comparators?
Yes, actually the tool package that with which we are collecting the data, which has been developed by optimate, it can be translated to any language. So currently it is translated into Finnish, Swedish, and English. And of course, we cannot say that we are doing something good in Tampere unless we are able to show and compare
Absolutely.
what we do to other countries. And for example, when talking about age-related macular degeneration, in 2017, Finland and Sweden had approximately the same number of injections, but the population of Sweden is twice compared to. So either we are over-treating in Finland,
or they're under-treating.
Or they are under-treating, and we don't know whom of us are under-treating or over-treating, and this is something that we really, really need to know.
Yeah. So what other conditions are you dealing with? Are you sticking to age-related degeneration, or are you also looking at things like cataracts, for example, another area of very significant variation?
Yeah, we are in the model currently, we have the tools for the big 4 eye diseases. First one is age-related macular degeneration, because it causes 60% of permanent visual disability. Number 2 is glaucoma. It's the second cause for visual disability. Third one is diabetic retinopathy. It causes visual disability. Cataract is the 4th one. It's the only one of the big 4 which does not cause permanent visual disability. And typically, the decision makers and politicians, they think that when cataracts have been operated, everything is fine within eye care, and that's not the case. So we include them, and the big 4 eye diseases in Finland account for approximately 70% of our care, patients, costs, and visits.
Now, cataracts is very difficult. It's very difficult to manage. In another life, many years ago, I was something called a fund holder. This was an English initiative whereby primary care clinicians, and I was one of them, held a budget, and I spent quite a lot of time trying to manage our ophthalmological spend, not in glaucoma, not in age generation, etc., but in cataracts. And the big issue is when to operate in cataracts, how ripe these cataracts have to be. Because if you look hard enough, I think everybody on earth would get an operation.
Yeah, exactly. So we have also a threshold. In Finland, the threshold is that if you are able to keep your driving license, that's fine. So, but I think that cataracts are operated even with better visual acuities. But I mean, if, for example, if I at the end of the year have 1,000 euros left of the budget, and I have on the waiting list a cataract patient and an AMD patient, it's easy to decide. Of course, I will treat the AMD patient.
Yes, I think there's no doubt.
Yeah, patient can lose the vision within 4 or 6 weeks. And the cataract patient might have a little bit difficulties, but still nothing serious happens to the patient. And it's also very easy to explain to the patients. I mean, it doesn't, when we prioritize oration, we are not leaving patients without care, but we are actually prioritizing, and also not only the diseases, but also prioritizing patients. So if we have a patient who has poor visual acuity because of cataract in both eyes, that patient will be prioritized for early care.
Now, there's also a real opportunity here, because of course we're using Optimate as the vehicle for all of this.
Yeah.
And Optimate, of course, is the vehicle which is really concentrating around the method of visualizing those
Yes.
fundi.
Yes.
So how do you choose Optimate?
Well, we organized a tendering, and tendering was supported by Business Finland, which is a government organization. And also Business Finland supported the development of the tools for Optimate. So we have been working now all together for 5 years within this project. And actually 2 weeks ago, we implemented the first data collection tool to glaucoma. We have had in Tampere a prototype since 2018, which was very useful for us, because then we were able to create the requirements for the tendering. And by the way, even before that, we have collected data since 2008 manually. We have more than 200,000 interventions, which we are evaluating. And the Optimate tool package also includes evaluation tools for aggregated data.
So this means you could use this in a whole host of places, which is wonderful.
Yeah.
So when do you hope to get the first bits of data out around this?
Well, actually, we have already published data with the prototype, and now we are developing for glaucoma. We have the prototype, also the structure for Optimate tool, but we need to develop that, because that's based only on our data. But when we are developing benchmarking model, then we need data from other centers.
Yeah.
And that is under development. And as I mentioned, we are considering whether it's a better eye, worse eye, and so on.
So now you know. This makes it all very clear what this whole project is about, and also how important this is, because of course in aging populations, and Finland is one of the most aging populations, certainly in a European context. The point prevalence of all these eye conditions obviously goes up really quite dramatically, from cataracts to age-related. It's even in the name, macular degeneration. So thank you very much for the opportunity you've given me, and really to explain what all this is about, because I think this is something which will travel all over the world slowly. I mean, I know of a couple of places in the Middle East where they're starting to do the same thing. I don't know whether they're doing it with the same platform, but if not, it would be worth having some conversations to see if we can expand that international comparator, because we're all after the most precise treatment, the most cost-effective treatment for patients and citizens. And I think what you're doing epitomizes what we should be doing in everything we do.
Yeah, and as the ecosystem is actually, the principles are adaptable to any specialty.
Any system. Yeah.
So we are trying to prevent visual disability, but it's I think it's the challenges are the same, regardless where we are delivering care.
Yeah, I agree, Anja. Thank you very, very much for spending a little bit of time with me, and we'll see you in a couple of weeks at the Radical Health Festival in Helsinki. Thank you.
Looking forward to that. Thank you very much.
Thank you.
Yeah.